All right, thank you again, everybody, for your time this afternoon. This is Matthew Menendez with White Plume. Our webinar today is going to be focusing on the changes that are coming up on October 1st. It's hard to believe ICD-10 turns 1 in just a few short weeks, and along with that, there are some changes that we want to make sure that you're paying attention to so that your practice is as prepared for this first anniversary as you were 12 months ago. So here's what I hope to accomplish over the next 45, 50 minutes. For those of you who are just joining us, welcome. Feel free to use the questions panel to ask questions as we go. So here's what I hope we're going to be able to cover today. There are two big changes that are coming on October 1st as it relates to diagnosis coding. Number one is the end of the ICD-10 code freeze. We've been under a code freeze for the past 5 years where there have been very limited changes to the ICD-9 code set or the ICD-10 code set. That was done by CMS as a concession to the industry to try to make that transition process go as smoothly as possible. I'm going to talk through this, but as you can imagine, we kind of have a backlog of changes. So this one is going to be a big change with some of the new codes that are coming out on October 1st. The other change that we're going to talk about is the end of the ICD-10 Grace Period. You remember this? One of the things that CMS did to try to make the transition to ICD-10 successful was to offer this 12-month grace period, saying that they would not deny claims for unspecified diagnosis codes. As long as you were within the code family, the claim would get paid. Most of the commercial carriers have followed suit, and the grace period is about to expire. That goes away on September 30th as well. So we have those two big changes that are coming, and we want to make sure that you're prepared for that so that you don't have any short-term or long-term negative consequences as a result of incorrect coding. We're going to talk through both of those, what the short-term risks are, what the long-term risks are, so that you can understand how to best mitigate those risks. We'll give you some tools to know how well prepared is my practice, how at risk are we, and then talk about, we're going to spend the majority of our time today on how do I take advantage of the next 3 weeks. How do we best prepare for these two changes that are coming, right? The good news is we have a lot of tools, we have a lot of resources that we can help you leverage that are at your disposal so that we can make sure it's a successful transition for you, it's a successful transition for your physicians, and it's a successful transition for your revenue cycle. All right, I know that's a lot to pack into the next 50 minutes, so hang on, we're going to move quickly, and if you've got questions as we go, feel free to ask those, and Shelly's helping me tag team this so we get all those questions answered as quickly as we can. All right, so the first thing is code freeze. What's happening there? Well, I mentioned before we've been on this code freeze since 2012. That means there have been very, very few new ICD-9 codes introduced, and it means there are very, very few new ICD-10 codes that have been introduced as well. One of the new ICD-10 codes that gets a lot of the publicity is a code for Zika, right? That's been in the news a lot recently. That's one of the new codes that has not been able to be introduced to the code set because of the code freeze. That's changing on October 1st. So there will be over 2,600 changes to ICD-10 on October 1st. And the majority of those are new ICD-10 codes. Nearly 2,000 new codes that are being added. There are many places where they are deleting a code and then adding new, more specific codes underneath that. There are many codes that are being added, like Zika, that weren't there at all before. You would have to use an other or unspecified mosquito-borne disease in order to correctly code that. And then there are others that are being changed. The revisions that you see here are typically they are just small changes to the description, the way that they have spelled that out in the code book, but that counts as a change as well. So you'll continue to see annual changes from CMS on these ICD-10 codes, but you probably won't see as many next year as we're seeing this year because of the code freeze. So you need to be aware that there are new codes that are coming out. There are old codes that are being deleted. But the takeaway message here that I would tell you is you don't have to worry about this. White Plume has you covered. There's a lot that we've been doing here to try to make that very, very easy for you. And what I'm going to do is give you just a couple of quick examples and show you how that impacts different applications in the White Plume product suite. For those of you that are using Capture and Mobile or Mobile, the way that where you might see that is in a custom scenario. So you may see a code that you used to click on that gave you 4 choices. It now gives you 5 or 6 choices. We've updated those for you automatically. Now, if you have modified any of your custom scenarios, there are some of you who have really gotten into that and that you've done a lot with those. You've already heard from your client account exec on that. You probably know who you are. If you don't know and you want to ask, just let us know in the questions panel. Client account execs will follow up with you on that. But for most of you, that's going to happen automatically in the update once those custom scenarios are loaded. Now, for those of you who maybe Pass clients, maybe you're capturing the charge data through your EHR, we can't update that for you automatically. That's something that you'll need to check with that vendor on. You'll need to make sure that your templates are well structured so that you're selecting the correct code there. But for all of our clients, we are making those changes in Smart, so there are new custom rules to identify if you're trying to use a code that's no longer valid. Or we also have rules that we can build in for you that will help you identify if you've got an unspecified code that might have a more specific alternative. We're going to talk a little bit about that in the second half of the webinar. So the good news is we've built a lot of this in there for you. So the new codes that are coming, we've got you taken care of. If you're using your EHR for code selection, you may want to review part of that a bit more thoroughly through your templates. Because that's really something that's outside of the scope of our control. We will make sure that it gets caught in Smart if something does slip through those cracks for you, though. So an example of a deleted code, T84.040S, this code is being deleted. It's not being replaced, it's not being modified, it's not being added to. It is no longer in the code set. And so if you try to use this code after October 1st, provided that you use the custom rules that we have sent you, that you import those rules, you'll see a rule just like this pop up in Smart. And what that's trying to tell you is, hey, this is a deleted code. It cannot be used after September 30th, 2016. A valid code today, not a valid code in the future. For those of you who have been around in this industry for a while, you probably remember this. This happened all through the 20 noughts. When we had these annual coding updates to ICD-9, you'd see rules like this that fire based on diagnosis code and date parameters. That's back now that we're done with the code freeze. All right, so Smart is going to identify those for you and make sure that you're not sending out claims that are going to ultimately get denied. Let me give you another example. All right, we're going to look at one that's a bit more complicated. This one involves 17 code changes as a result of the end of the ICD-10 code freeze. H35.32 is being deleted. And then you can see there are 16 new codes that are added underneath that. So it's not enough just to have the exudative age-related macular degeneration anymore. For those of you that are in ophthalmology practices, this is the wet macular degeneration, right? You now have to be more specific. You have to be more specific as far as which eye are we talking about. Is it the right, the left, the bilateral? Or if you see those that have the next to last character is a 9, that's an unspecified eye. Probably don't want to use that. But we also have to say, is this with neovascularization? Is it with inactive neovascularization, with an inactive scar, or an unspecified stage? I've got to be more specific here than before. And you can see the trend that Medicare and the other payers are wanting increased specificity. They want that higher level of detail. That's why we made the switch to ICD-10 in the first place. That's why the grace period is expiring. That's why the code freeze is expiring, because they want that detail, and they're ultimately trying to use that data long-term to bend the cost curve back down, to reduce healthcare spending. They're going to use this data against you. We need to be very careful and make sure that we get this right the first time. So one deleted code here in this family, 16 new codes that are added on October 1st. So how does that work itself out? What does that look like to your end users? Let me show you the example, because I'm a visual learner. I think it helps to kind of get in here and see what this looks like. So what you've got here is on your form, you have that macular degeneration WEC, right, on your form today. When you click on that, before October 1st, it will convert automatically to that H35.32 code, right? You're all familiar with seeing this in your application today. Whether you're in Excelomobile or Excelicapture, you click on that code, and many times it converts automatically to an ICD-10 code. Now, that code is no longer valid on October 1st, 2016. That is one of the deleted codes. All right, so what happens on October 1st? This is the beauty of it. You don't have to do anything to get the right code. When I click on this the next day on October 1st, I get my pop-up, and it shows me the 12 choices for left, right, bilateral, with active neovascularization, with inactive neovascularization, with an inactive scar or an unspecified stage. I can select the right code. And what you'll notice is that this custom scenario does not include the choices for an unspecified eye, because there's no such thing. It's either the left eye, the right eye, or both, right? And we want to make sure that we get the right diagnosis code so that we get our claim paid completely and correctly the very first time. All right, let me give you another example, because I think if you've got a couple in your head, you can start to see how this is going to play out in your world. Maybe you're not an ophthalmology practice. Let's look at an orthopedic example. This is another example of one code that was deleted and 4 new codes that were added. So we're talking about cervical disc disorders with radiculopathy. I used to just have one code for the mid-cervical region, that M50.12. That code, again, is being deleted as a result of the code update on October 1st. And there are 4 new codes that are being added in its place. C4, C5, C5, C6, C6, C7. I've got to be more anatomically specific, right? There is a code for unspecified level as well, right? I know it's mid-cervical, but I don't know which one. All right. So again, let's take a look at what this looks like today, how this would work in Excelicapture or in Excelomobile. If I right-clicked on it in Excelismart to get the pop-up, right? Today, when I do that, I get a pop-up and it shows me my choices, right? And you'll see it's got that one choice, the second one from the top, for mid-cervical, so that I can select the appropriate diagnosis code. It closes my custom scenario, and I'm finished. What that will look like on October 1st with the new custom scenario is my list gets a little bit longer. It replaced the M50.12 with M50.121, 122, 123, so that I can be more specific anatomically. Just to give you, to see that side by side, what you'll see, that the ones that are highlighted in yellow are in both custom scenarios, both the old and the new. The old one just had one code for mid-cervical. The new one has those 3 more specific choices. You can see that's still organized the same way. It just includes those new choices in there for you automatically. You don't have to make those changes. You don't have to do anything differently, except make sure that you've updated your custom scenarios with the information that we've sent you, and that you've imported those new rules to make sure that we are identifying any old codes that you don't need to be using anymore. All right? So that's the first change that's happening on October 1st. The end of the code freeze. We will have many, many new codes. We will have some deleted codes. All in all, it's about 2,600 changes to the code set. But most of that we've been able to do for you behind the scenes. Now, the second big change is the end of the ICD-10 Grace Period. And we've talked about this before. You'll remember that in the lead up to ICD-10, in the lead up to October 1st of last year, everybody was really concerned and really worried. Consultants were recommending that you get a line of credit in place to fund 2 to 3 to 4 months of operating expenses in case cash flow came to a halt. Medicare predicted that denials would double or triple because of ICD-10. But the data that we've seen thus far shows us that denials haven't increased at all. You've probably heard this from peers, from people in other practices, from people in trade groups with you, that ICD-10 was a non-event. It was like Y2K. Everybody was really concerned about it, but it didn't come to fruition. And I think one of the big reasons why we had the big concern and nobody saw the negative results that everyone was afraid of is not because ICD-10 was really, really easy, right? It's not that. There were a lot of new codes that we had to deal with. That was a big change. It was not that our doctors were just as specific as the payers wanted us to be. What happened was we have not seen the real impact yet. What happened was that Medicare offered this grace period, and that grace period is about to go away. And that means we haven't seen any of these denials yet. That risk is still ahead of us, not behind us, right? You remember when they put out that press release last year, one of the big things that they said that they agreed with AMA on was that they would not deny claims because of lack of specificity before October 1st, 2016. And they've been very clear in some new Q&As that they've released on the web, some FAQs that they've released on the internet, that they will not be extending that grace period, that they will start denying claims for lack of specificity. Being in the right code family is not enough. And so the concern, not for many of you, but for the industry at large, is that there are many people that are using unspecified codes and they are blissfully unaware of it, and that they will become aware of it not until they start to get those denials back. Right? So we're running out of that grace period. They said they wouldn't penalize you in the PQRS or value-based modifier programs as well, and that expires on October 1st also. Right? So we have these two big risks to using these unspecified codes, the short-term risk and the long-term risk. Let me talk about both of those briefly. The short-term risk, which begins on October 1st, 2016, about 4 weeks from now, is that claims are going to start getting denied. The entire reason that we moved to ICD-10 was to have a more specific diagnosis data available on our patient populations. That's what Medicare wants. That's what the commercial payers want. And their only recourse, if they're not getting that, is to deny the claim. And when they do, that stretches out your accounts receivable. It slows down your cash flow. It requires coders to stop, resubmit the claim. It requires coders to stop, go back to the chart. It requires coders to stop and go back to the physician, to the clinical staff. It requires them to take time away from their own schedules or take time away from patient care to answer coding questions. And that's not good for anybody. It's not good for your revenue cycle. It's not good for your billing staff, and it's not good for your clinical staff. That's what we want to avoid. We've seen very, very few payers who are already doing this. Georgia Medicaid is probably the first one that we saw to deny for unspecified codes. We've seen a few other payers in Texas and Arizona that have done this as well, but we expect the majority of payers to begin denying these unspecified codes starting next month. When that grace period expires, Medicare will start doing that, and the other payers will as well. That's the short-term risk. That's what we want to avoid, and that's what I'm going to spend time talking about how do you do that over the next 3-4 weeks to get ready for October 1st? But I do want you to know that there's a long-term risk to these unspecified codes as well. And the long-term risk really starts to take effect January 1st of 2017. All right? Everybody has heard we're making the shift from fee-for-service to value-based reimbursement. Medicare and the commercial carriers want to start measuring and paying for value, right? That's what happened in the macro legislation. That's what's being measured, and incentive payments and penalty payments are being doled out under MIPS as a result of that legislation. We talked about this on another webinar. I don't have time to go into it in detail today, but the two biggest components of anybody's MIPS score will be quality and cost measures, or quality and resource use measures. And those measures are risk adjusted, meaning it matters how sick your patients are. The sicker your patients, the higher the expected cost is for those patients. The sicker your patients, the worse outcomes are expected for those patients. And in order to maximize and make sure that you are accurately getting the dollars and credit that you deserve, you have to be able to show how sick your patients are. And that includes making sure your diagnosis coding is done correctly, using those HCC codes to show how sick your patients are, to accurately reflect patient acuity, right? So that your quality and resource scores are reflected accurately as well. So our diagnosis coding is about to become much, much more important than it ever has been before, both the short-term risk and the long-term risk, okay? In the short term, the best thing that you can do is get your diagnosis coding as low as possible. I'll share some data with you of what we've seen when we look across our client base, when we look across the industry at large, and give you two snapshots. What this looked like in March at the end of Q1, and what that looks like currently as we approach the beginning of the fourth quarter. You can see the national average hasn't changed much. It's pretty high. Nearly 1 out of every 3 diagnosis codes that are used are an unspecified code. You can see the White Plume client average is much, much better than the national average and has gotten better over the past 6 months. You know, that is a huge congratulations to you, to your teams, to your providers, for you to be able to brag and show how well you're doing compared to your peers across the country. And you're never going to get that number to 0. Right? There are appropriate times to use unspecified codes, but you want to be trying to get that number down. All right? I want to brag on 2 things here on this slide. You know, the first is looking at our client results compared to the national average, because your results are 3 times better than your peers across the country. 3 times better than your peers across the country. And as the payers begin to crack down and deny unspecified codes, you're going to start to see those results. You're going to start to see some of your colleagues struggling with some of those denials, having to go back and change some of their processes to get more specific codes on their claims so that those claims can get paid. But we expect that you'll have much, much less pain than your peers because of how well you're doing on that today, right? And the second part that I would draw your attention to is look what's happened over the past 6 months. Many of you have already put in a lot of work. You've worked with your client account execs. You've worked with our support team. You've worked with our forms team to try to reduce your unspecified rate. And you've been able to actually move the average in our client base down 33%, 33% improvement over where we were in March. For those of you who have already done that, awesome job. Way to go. For those of you who have not done that yet, I would point to this as a reason for hope that it can be done. It takes some time. It takes some work. We are here to help you. Even if you've already done this once, you may want to look back and think about doing this again. Can we get our numbers down a little bit further? Right? Or there's still places where we're using unspecified codes where we really shouldn't be. And that's why it's important to know what is the unspecified rate for your practice. What is the average for your practice? What was it in Q1? What is it now? And where do you want it to be in the future? Because that's the best place to start. So when I'm trying to answer the question, over the next 3 or 4 weeks, how do we improve our unspecified rate? I have 5 recommendations for you. A 5-step process that you can go through to achieve those types of results. Number 1 starts with your unspecified analysis. Everybody should already have this in hand. If you don't, let us know. Let me know in the questions panel. We'll get your client account exec on that to get you a fresh copy. If you need an updated copy, you haven't done that in a couple of months and we need to do that again, let us know in the questions panel so that we can begin pulling that data for you, getting you that report, getting you that information as the first step in this process, right? We've got 3 or 4 weeks before the payers start to deny. Let's get out ahead of this, right? And then the next thing that I would say is take that analysis and work top down. Let's focus on the unspecified code that gets used 100 times a day rather than the unspecified code that gets used 2 times a month, right? That is the best way to get your unspecified rate down very, very quickly, is to work top down, right? I know it's rocket science, right? Next thing that you do, when you're working top down, you want to look at those unspecified codes. And I'm going to walk through examples of all of these. This is just our overview before we dig deep. And decide, is that unspecified code appropriate or is it inappropriate? There are acceptable times to use an unspecified code. There are times when we don't know what is causing that problem. We're waiting on lab tests back. We're waiting on an imaging study back. I can only use an unspecified code because we don't know what's causing the problem. That's an appropriate time to use an unspecified code. Sometimes there is not a specific code available for what that patient has, and you have to use a not otherwise classified code. That's okay. But there are other times, there are other codes that we should probably never use, and you want to be able to distinguish between those two so that you can take the next right step. All right? On appropriate unspecified codes, what you need to be prepared to do is to push back against your payers, particularly on the ones you're using frequently. Again, we want to work this top down. If you've got an appropriate unspecified code that you use frequently and you have a payer who is overly aggressive, takes an overly aggressive approach on unspecified codes, and we saw this with Georgia Medicaid, they started denying any code that was unspecified. Even if it was an appropriate use of unspecified, they denied it. You need to be prepared to push back against your payer on that, right? There is not a more specific code to use. You don't know what's causing the problem, and you don't want to have to fight them on that 100 times. You want to know that you do that. It's a high-frequency code for you. You want to know that it's appropriate, and you want to be prepared to fight back the very first time you see a payer make that mistake, so that you don't have to fight it again and again and again, so that it doesn't hold up your cash flow, so it doesn't rob your revenue staff of valuable time. And then the last step, step 5, is when you have inappropriate unspecified codes. Working top down, let's put in workflow processes to prevent that from happening. Let's build that into our custom scenarios. Let's build that into our custom rules to make sure that we get the right code the first time, right? So that you've got a good process in place to get that unspecified rate down. So those are the 5 steps that I would recommend. I'm going to walk through those in greater detail. I'll go through each of them in that order, but I wanted to give you the roadmap of what we're about to do, what we're about to talk about. Okay? Now, for those of you, let me call a quick time out. For those of you who this is overwhelming to, if you said that's a lot of stuff for us to think about, a lot of stuff for us to do in the next 3 or 4 weeks, that's okay. We understand. We are here to help. If you have some of these that you say, you know what, yep, I want to do this, but will you just do some of this for me? We can help you with that too. Let us know. Put it in the questions panel. I'll have the client account exec follow up with you on that. We can offload some of that work for you if you need the help. Okay? Step 1 is the unspecified analysis. Let me just go back through this real quickly. Most of you already have this. Again, if you don't, or if you need a fresh copy of that, let us know in the questions panel. We'll get that out to you. But it shows here's where your unspecified rate is for your practice. Here's where it is compared to other White Plume clients. And here's what the national average is. I think this is great data, great information to share with your management team, to share with your doctors as we come up on the 1-year anniversary of ICD-10, and we're saying, hey, these are some of the changes that are coming. This is what the government's trying to do. Look how much better our team is doing compared to our peers. We are well positioned. You've done a lot of hard work to get to this point, and it's worth bragging about, I think. It also gives you some more detailed information at the bottom that shows you how your individual providers are doing. So that if you've got certain doctors who are doing better than others, who might need a little bit of help or a little bit of retraining, it's a helpful tool to point that out. And a little friendly competition never hurt either, right? Now the second part of this analysis is really what we're going to use to work top down, to eliminate some of those unspecified codes, to figure out which more specific codes are some good alternatives. And so the second part of this analysis looks through and shows you your most frequently used unspecified codes, ranks them high to low by how many times they were used during that reporting period. In this case, from October through December of last year. So the first code was used 2,200 times during that time period, and we think that there are 5 other codes that are reasonable alternates that you might consider that are more specific. Rather than just coding unspecified hyperlipidemia, we might want to use, E78.0, .1, .2, .3, .4 to be more specific here. May not always know, but if you have that, we do want to use the more specific code. Okay, there may be others, like the second one on here, vitamin D deficiency unspecified, that may not have any reasonable alternative codes. It may be an acceptable, appropriate code use. Okay, so let me give you a couple examples there as we walk through it. The first one is an appropriate use of an unspecified code. We saw on the previous slide, vitamin D deficiency unspecified. You look in that code family, and right now there are only 2 codes. It's either rickets or a vitamin D deficiency unspecified. You may have an overly aggressive payer who says, you know what, I'm going to deny that E55.9 because that's an unspecified code, and we want you to be more specific. But unless the patient has rickets, you can't be more specific. There's nothing in between those 2 codes. Now you can see that there's room available in the code set for maybe a future code release that has an E55.1 or .2 or .3, but that doesn't exist today. So this is a case where it's an unspecified code that is used appropriately. It's acceptable, and it should be acceptable to your payers. And if it's not, you need to be prepared to push back against that. You need to be prepared to fight them on that, and you want to fight that as quickly as you can. That's why it's important to have your analysis. It's why it's important to work top down, to know whether it's appropriate or inappropriate, so that I'm prepared the very first time I see a denial, and I hope it doesn't happen to you. But the very first time you see a denial for E55.9, I want to follow up with that payer right then and there. So that, because I know that that's going to happen in my practice 100 times a day, and I want to catch it on day one. Okay, so that's an appropriate use of an unspecified code. That's why you're never going to get your unspecified rate down to 0, because you're always going to have some of those that are appropriate. Let me give you an example of an inappropriate use of unspecified code. Osteoarthritis, M19.90, unspecified osteoarthritis of an unspecified site, right? The problem here is if you go look this up in the code book, you'll see 95 other ICD-10 codes that are more specific, right? And what we see is the unspecified code is used at a disproportionately high rate. 11% of osteoarthritis diagnosis codes are this M19.90 code. And that's problematic because it's unspecified as far as the type of osteoarthritis. Is it primary? Is it secondary? Is it post-traumatic? This code is also unspecified as far as which joint are we talking about. Osteoarthritis of the knee, of the wrist, of the hand, of the hip, of the shoulder, which joint. And finally, it's unspecified as far as the laterality. Left knee, right knee, both knees, right? This is an example of where the payer would be able to legitimately deny the use of an unspecified code, right? This is probably one of those examples that we should rarely, if ever, use. So that's why you want to work top down. And I would say when you're thinking about this, trying to say, is this diagnosis code, is this unspecified code appropriate or inappropriate? I'd put it into this framework. Put it into this grid. If it fits into the top right corner, right, meaning high frequency, we use it often, and it's rarely, if ever, an acceptable use of an unspecified code, those are the ones you want to correct. We want to put more specific choices in there. We want to build in custom scenarios, build in custom rules for that. If it's in the top left corner, meaning high frequency, but usually, if not always, acceptable to use that unspecified code. We want to be prepared to fight back against our payers, and I'm going to work myself top down. I'm not going to worry about those low frequency codes until I've already taken care of the high frequency codes. All right? I use this just to give you a framework as far as how do you think about it? How do you think about it? How do you put that into practice when you're trying to decide is that an appropriate code or an inappropriate code? All right? So for the inappropriate codes, we need to be prepared to fight back. We already talked about that. What about the ones that we really shouldn't be using? Like the osteoarthritis example, right? What I recommend doing is taking that unspecified analysis, taking that data that we give you, and using that to examine your workflows, using that to make changes to your custom scenarios, using that to make changes to your custom rules. All right, so let me give you a couple of examples of those, and I'll walk through a couple of those for you, and then I'll try to leave a couple of minutes for questions and answers. I know we're moving quickly here, but I hope that this is helpful for you. So start with that unspecified analysis, and let's look at that hyperlipidemia example that we talked about, right? Let's look at that hyperlipidemia example. So here I've got it on my form, and when I click on that, what you're going to see is I get that pop-up, and I might get that custom scenario with E78.4 or E78.5. Well, that's not as specific as I want to be. I want to be more specific. That's why they're choosing the unspecified code, not because they're lazy, not because they're bad coders, because those are the choices that they have. So how do I allow for more specific choices? Well, what we've done in our work with some other clients is change that custom scenario. Use the unspecified analysis to show you here are the alternate codes that you might want to consider. and put those into the custom scenario. Make it easy for them to choose. Let's put the unspecified code at the bottom so that they won't use that code unless they really, really need to. Some people, in the examples where you say you should never use that unspecified code, they'll take it out of the custom scenario altogether, right? One example of how clients have changed that, right? Let me show you a second example. And this time we'll look at the unspecified osteoarthritis code. And what this client had done in their previous world, they had changed the description. 71596 here was an unspecified osteoarthritis code, but they changed it to be osteoarthritis of the knee. They used 71596 for osteoarthritis of any joint. And the problem with the mapping was that that code would automatically map to the unspecified osteoarthritis code. And that was okay, because remember in the past, payers were not denying for lack of specificity like this. They really let that slide in ICD-9, and B, they also allowed for that grace period over the past 12 months. So this hasn't caused a problem for a lot of people yet. But our clients that we've been working with to try to reduce their unspecified rate, what we've done there is said, we don't need to change the form. We can leave the form exactly as it is today. What we need to do is change the custom scenario. And we know by looking at the diagnosis data that the far and away the most likely joint for osteoarthritis is the knee. So we stack this scenario with organize it by joint, but we put the knee at the very top of the list, right? So that it minimizes their view, makes it easy for them to sort through the available choices, and they can change that to the shoulder or the hip if they need to. Other clients, what they would prefer to do is not have that drop down at the top, but just go ahead and list out the different joints for me as well. Okay? Now you'll notice there are still some codes that if you want to use bilateral, like bilateral osteoarthritis of the foot, you would still have to use two different codes for that, one for the left foot, one for the right foot. Okay? That is a problem that will eventually be solved as CMS continues to add new codes after the code freeze. They're just not in this first release. They're not there yet. And it's probably because not enough people have been requesting that be added to the code set, which is probably because not enough people actually have bilateral primary osteoarthritis of the foot. So just a couple of examples of how our clients have been changing that in Excelicapture, changing that in Mobile in order to make sure that they capture the right code. They can drive down that unspecified rate. When we're seeing clients see a 30, 40, 50% decrease in their unspecified rate, it's because we've been working with them to do this. Now you can also do that in Smart. You can build in a rule, right, that says, you know what, when I see this unspecified code, I want you to stop my billing employee. I want you to stop my coder so that I can review it and not only tell me what's wrong, but show me how to correct it. Show me what the more specific choices are in ICD-10 so that I can review my documentation and make sure that we code that diagnosis code accurately, right? And what that error looks like, right? When I see a patient right here with EA78.5, it's going to throw that error message for me, throw that custom rule in Smart that lets me know it's an unspecified code, that let me know it's now at risk for a denial, and shows me here are the more specific choices that I have available as well. This is just a bonus tip for you that many people don't know. You can actually get those custom scenarios, those pop-ups, here in Smart also by right-clicking on the diagnosis code. So if you want to leverage that for some of your coders, for some of your billing staff, you want our help in that, we're happy to work with you on incorporating that into your Smart workflow as well. I know I went through a lot of information. I know by Shelley's typing over there that she's been trying to answer as many questions as she can. Don't worry, if you've got a question that hasn't been answered yet, we'll make sure that we answer all of those offline, right? If there are some that we can't get to today, or there are some that takes a little research, Don't worry, we will follow up on those, and I'll make sure to leave the questions panel up for a few extra minutes after we finish, in case there's anybody who decides they wanted a link to the recorded version or they needed a new unspecified analysis run. So what have we covered? What have we talked about over the last 50 minutes? Your takeaways for today. Remember what happens on October 1st, 2016. ICD-10 turns 1 year old and the code freeze expires. And the grace period is over. Those are the two big changes. We've tried to build in all of the new codes. We've built in rules for you to try to make that as easy as possible. We've tried to give you the custom scenario, the unspecified analysis, right? So that you're equipped to make your unspecified rate even better than it is today. Share that information with your team so they understand why this is important. Because there are short-term and long-term risks if you don't do your diagnosis coding well. The first risk is the short-term risk that begins in October in just a few weeks, that those claims are going to get denied. If we use unspecified codes, both Medicare and your commercial payers are going to start denying those claims. And then in January, risk-adjusted coding becomes very, very important as the first performance year in MIPS. You've got to make sure you're accurately reflecting patient acuity, right? If you've got questions on this, again, let us know in the questions panel. We've got webinar content that's very helpful for you. Your client account execs can work with you on this. There's a lot that you can do in Capture, in Mobile, and Smart to make sure that we're accurately capturing those HCC codes and those comorbidities from a risk-adjusted perspective. But in the next 3-4 weeks, you want to take that unspecified analysis to know which unspecified codes you're using most frequently, to work those top down, to understand which ones are acceptable, which ones are never acceptable, and to put processes in place to make sure we're getting our unspecified rate down as low as possible. Right? We want to prevent and correct those unspecified codes through custom scenarios in Capture, through custom scenarios in Mobile, and through custom rules in Smart. If all of that is overwhelming to you and you'd say, you know what, I would love for White Plume to just do some of that for me. I understand why it's important, but I don't have the right people, or I don't have the right resources, or frankly, I just don't have the time to do that. You want us to build in the custom scenarios, build in the custom rules for you. That's something that we can offload for you, and we can do your top 20 of those for $2,000, right? That's kind of a one-time thing. We'll offload that work. We'll deliver the rules. We'll deliver the custom scenarios. If you need the help, let us know. We've got a few spots still remaining for that. If you've got it and you understand how to use the tools and you don't need our help, or you have support questions, feel free to ask us about that too. We just want to help make sure that you and your team and your doctors are successful as we come up on this 1-year anniversary of ICD-10. Thank you very much for your time. I hope this was helpful. I hope I didn't move too quickly for you, but I'm going to try to answer some of the questions, the common questions that Shelley got that are broadly applicable for the wider audience.
The first one is, what about procedure code changes in this update?
The procedure code changes are there as well. You'll get those as the Alpha 2 update that we do every quarter. Those are much, much smaller and much, much lower risk than the diagnosis code changes that we have this year. Really, as a result of the code freeze, we've kind of built up a backlog of diagnosis changes that are all coming out at once.
Also, when the client account execs sent the emails out that included the custom edits, would you clarify the difference between the edits that we sent versus edits for unspecified laterality?
We did not send, I don't think we sent any edits for unspecified laterality, but there is an email that is coming for that that'll have a few rules that are basically identifying any of the unspecified laterality codes. Those are the worst offenders, the one that you should never use. So keep an eye on your inbox for that. That one will be coming shortly. You will need to import both the rules for invalid codes and the rules for the unspecified laterality codes if you want to use those and deploy those. And if there are any other rules that you want to build for unspecified codes that you should never be using, you can build those custom rules in just like you always do in Excel Smart. If you need help or want White Plume to do that work for you, we can certainly help you with that as well.
Okay. The last question is, when can I expect to get the update for those custom scenarios emailed to me? So I'll answer that one. That you will receive, all of our clients will receive an email from our client services department, otherwise known as support. That will probably come from Carol Johnson, and that will include the utility and the instructions to run that utility on your system. So you can expect that in September, toward the end of the month. That'd be this month. But once that update utility runs, those scenarios will be changed. So ideally, you will do that at the end of September once your September charges have all been entered into Acela Capture, so that if you're a Capture user, so that those scenarios won't change for September charges, but they will be there updated for your October charges. So we will recommend that you run that utility on Friday, September the 30th.
Great. Thank you, Shelley. And thank you, everybody, for your time this afternoon. We're right up against our end time, but what I'm going to do is I'm going to leave the questions panel open. If anybody's got any last-minute questions that you haven't asked, if you've got any follow-up information that you'd like for us to follow up with you on, if you've got any feedback for us on the webinar today, you can use the questions panel for any of those things. So thank you for your time. I'll leave you with this last thought. The majority of you on the call today are doing much, much better than your peers as far as your unspecified rate. You're in a much better place to be successful in the transition, A. B, because by virtue of the fact that you are here and that you're paying attention to this, you are more likely to be able to adapt successfully as the payers begin to deny these unspecified codes. So don't be scared by it. You're in a good spot. You have done an excellent job already, and you will continue to do an excellent job and outperform your peers in this area, right? If you need help with that, if you've got questions, if you've got concerns, let us know. We are happy to help and glad to be your partners in making this transition successful. Thank you again for your time. Thank you for being wonderful clients. I hope you have a great rest of your Wednesday afternoon. Bye-bye.